Record. Cool. So, so tell me a little bit about, like, have you been watching the show for a while, or tell me what's going on?
Don, there's a message that kind of covers your face now. It says this meeting is being recorded. Let me see if I can get rid of it somehow.
Just click it there. Just click that message and then just say okay or something like that.
Oh, okay. Yeah, got it. There you go. Yeah, no, you know what? I don't know. Honestly, I don't even remember. I think I saw you through podiatry management emails somehow.
Okay.
And
Yeah.
I kind of clicked on it because I'm up always for new things. And I saw your interviews, a couple of interviews with other people. And then I got intrigued when then I got into the website somehow, and I liked the idea of sending the patient information, educational information that you use through, what is it, Patient Genius?
Patient Education Genius, yep.
And that was, I wanted to kind of pick your brain on that and see, how that's working. I'm intrigued by it.
Yeah, what are you doing currently?
I just print a piece of paper out of my TrackNet that has some education on whatever the condition is. But since I started doing it, I find it very powerful. I think patients really respond to it. When I hand it to them, they're always like in a very thankful, oh, thank you for giving me this, because they know that they're going to go home and they're not going to remember anything I told them. So I wanted to take it to the next level. And I liked your, the Patient Education Genius. And so, and I, wanted to chat with you a little bit, basically.
Yeah. Okay. So I can explain how I got into patient education. Basically, we used to use something called Postwire, which is an old product that's not there anymore.
Okay.
And it was actually used initially by physical therapists. And so what they did is they had patients come in and they taught them exercises, and then they used to send them videos of their exercises to remind them how to do the exercises. And then we basically took it to be like, well, we wanted to give a better patient experience. And so we started to use Postwire. And the cool thing about Postwire is each one of those pages were encrypted, and like it was like HIPAA compliant, so you can talk back and forth to the patients. But the problem about that is it wasn't in your medical record. It was more in their little app. But they closed. They sold it. And I was looking for something else and I couldn't find anything. And then I came up upon this company called Patient Education Genius. And what I feel, and the same thing you said, is like our patients, we talked about plantar fasciitis, man, they can't remember anything. They leave, you tell them everything, and they leave thinking you called them fat or something, And so what I did is it's in the beginning, I was just sending them like the stuff from ACFAS, the stuff on plantar fasciitis, and I was just sending them those things. And then as I started to do like these presentations, I recorded a video and I sent them the video. And then as I learned how to do books, I sent them books. But then it got to be too much. So I'm just telling you my mistakes. So it got to be too much crap, and like they wouldn't. And like, how many people are going to look at stuff anyway? You know what I'm saying? So you might be right with just doing one thing that they'll actually look at. So where that took me to is now I send them a link to my website, which has everything for that diagnosis. That's where it's at now. So I send them one link. In Patient Education Genius, the benefit isn't the patient education. The benefit is every patient is asked for an online review.
Yes.
That the real benefit is that. So I send it to everyone, and then I say, hey, by the way, there's going to be this little bot, and it's going to ask you to give us an online review. If you had a good experience or bad, just let us know either way. So that the main benefit is getting online reviews. The secondary benefit is they get something from you. They get that Patient Education Genius. So that's that.
And do they respond to reviews?
Like, yes. Like, and that's how so there's a couple ways I get reviews. One is Patient Education Genius. The other one is we use a website called Patient Pop. And so every new patient gets an email from us asking us for a review. If it's not automated, it won't be done. So that's my thought. If you it's dependent on you, the doctor, to ask them, or the staff. It's not
Yeah.
going to be done. So it has to be automated. And frankly, all my patients come in because of Google now. It's not even the primary care. Like, I'll ask them, how'd you hear about us? They say Google. And I ask, well, who's your primary care? And I'm like, oh yeah, I know that. If you would have asked your primary care, they would have sent you. But since you didn't, that's how you got here now. So most of ours come from Google now.
Really?
And even if they have a primary care and they recommend you, they're going to Google your name. And if you don't have a ton of reviews, they might choose someone else. Like, we have 10 times reviews more than anyone else in the city. Because we have a system, not because we're 10 times better, just because we have a system. It's a system.
So what makes you how do you get all these patients from Google? How do you optimize yourself?
Well, it's only the reviews. It's just the reviews.
Only
That's
the
it.
reviews, really?
It's only the reviews. Yeah. The Google My Business. It's called Google My Business.
Yeah, no, I
And
have like 108 reviews.
Yeah.
So
Well, it's not about, if you have 108 and no one else has any, that's great. But if another guy has 1,000, they're going to choose the guy with 1,000.
yeah,
That's just the way it is.
Yep.
So how can you 10x your reviews ethically? Basically, it's every patient has to give you, because I know we're all good doctors. They're not 100 times better. So you just have to have a system. That's why I'm a big advocate of a system. So if you don't have a different way, you might want to consider patient education. I think it's about $100 a month. But if it gets you, let's say, 10 reviews a month,
oh, that's great.
It might be worth it. So that was the first thing. So what else?
I have two of them: how to increase the patient value, which is kind of general, and Onyfix. Let's go to Onyfix. I know you promoted Onyfix, or you spoke about Onyfix. I heard you mention it. So I contacted the company. I was like, for these repeated ingrown nails, I have a lot of kids who come with, over and over and over for ingrown nails. So but the feeling I got from them is it's not really for repeated ingrown nails. If the nail is flat, Onyfix is not going to fix it. So just trying to get more cash services, basically.
I don't get paid by Onyfix. Okay. The two things I do for nails are the Keryfex and the Onyfix. So the Onyfix, I'm very selective. So if you have an active paronychia, you're going to do an IND. Okay. If it keeps coming back, you're going to do a matrixectomy. But I find that the Onyfix are for those people that they come in with an ingrown toenail that's not infected. It's straight at the proximal aspect and it's incurvated at the distal. So if it's straight, if it's more rectus at the proximal, you can apply this thing like a brace, and as it grows out, it gets curved. This way it stays straight and it slowly lifts it up. Now there's a few drawbacks. Sometimes it falls off. You have to learn how to do it. And it's expensive. I charge $125 per application, and I usually do 3 to 4 applications. And I do these applications, about 4 months apart, 3 to 4 months apart. So I'll guarantee it to last like for 3 months. And if it falls off, I do it for free. Okay. I only do the big toenail. Very rarely do I do the lesser toenails. And I heard one other doctor, he was talking about it, and he basically said, and I don't want to poo-poo any professions, but we're very surgically trained, and we can treat with matrixectomy and paronychias for INDs. Other people, like nail salons, they don't have those options, so they're going to use it on everything. And so I think that's the main difference. I don't use it. I don't even do it once a day. I may do one a week when it comes in. And what worked better was when my colleagues, like these patients that had an ingrown toenail, but they didn't want a IND, they would send them to me and I would do the Onyfix because they wanted to try something else. So I use it kind of as let's try this and see how it does. That's how I use it. And we charge $125. It takes me about 10 minutes to do. It's pretty easy. And then they come back every 3 to 4 months.
Right. And you have to use it over and over, right? If you stop using it, the nail will go back in?
No, the thought is because the nail takes 9 months to grow out, there's going to be it's going to, in 3 months, there's going to be that new growth of nail, and you apply it proximally to there. So you're always applying it proximally, and so you have 2 strips 4 months later, and then usually that distal one falls, and you're always having like 2 strips on there. And as it's growing, so after the 4th one or 3rd one, then you're done. Then the nail is a little bit less thick. It's not totally straight, but I'm sorry, a little bit less incurvated.
Yeah.
And so it helps as well with thickness a little bit too.
Yeah.
So
yeah,
Keryfex. Yeah, go ahead.
Yeah, how do you, I mean, again, that's another one that's like, I don't find a lot of use. I have it, I do it, but I don't know whether I'm not promoting it properly, or I just haven't used it as often as I thought I would when I first got into it.
Yeah, I feel the same. So with Onyfix, first of all, I think any of these cash procedures, the more we learn about them, the more we're going to do. And that's really what I've learned. Like the more webinars I do, the more I learn about what other people are doing, like you're doing talking to me, it's going to build your confidence. And in the beginning, when I started Onyfix, I charged like $50. Like I charged a lot less just for me to learn how to do it. And actually certain patients, I didn't do it. I didn't charge at all. I just got it and put it on everyone just to see what it was like. You know what I'm saying? Because the more you do it, the more confident you get at doing it. Because Onyfix doesn't have a very big learning curve, but you have to be confident. So I just did it for free, just to try it. Hey, let me try this thing out on you. You have a little bit of, just see how it goes and get their feedbacks. Because if I don't believe in something, I can't sleep at night. So I'm not going to do it. That's why I don't want to, gosh, I shouldn't say it's just the 2 of us, but unless all the listeners, I don't do epidermal nerve fiber biopsies because I can't sleep. I'm like, is that going to change how I'm going to treat neuropathy? No. And, and so I just couldn't sleep. I did them in the beginning. I'm a big practice management guy, but I'm like, it didn't affect it. So let's talk about Keryfex, so I don't get in trouble talking about bad about other things. So Keryfex, that is the only treatment that makes my patients cry for joy. So I have patients that in what they'll tell you the same thing. These are not fungal toenails. These are nails that have had trauma, or nails that have ingrown procedures in the past, and they just did like a bilateral matrixectomy and it looks like yuck afterwards.
Yeah.
Or the women that has trauma, or onycholytic nail from trauma. So these ones these are the women, because it's all women, that never wear flip-flops or open-toed shoes because they're embarrassed. These are the ones that cry. So these are the ones that come in and see me every 3 months, and I put a new one on them, or every 6 months, or every summer. And in the beginning, it has a learning curve. Once again, I would do it for free the first few times to learn how to do it, because in the beginning, the darn thing is this thick and it looks ugly, and your patients hate it. And so what you do is you have to get a lot of them scheduled. You just do them for free till you get your practice. Because the thing is, if you don't know how to technically do it, it's going to look like crap.
Yeah.
Because I don't have like a ton of nail grind. We don't do a lot of nail care. So I don't have a ton of nail grinders or things like that. I had to buy a Dremel just to do it because I don't have a Dremel. And so you have to like Dremel it down a little bit, the nail, and you have to get the nail real thin before you put it on. If you have a real thick nail, the thing's not going to fit on there. It's going to have the Keryfex and then a thing poked up from that dorsally, that nail that's stuck up. So I grind down the nail, then I put it on, and it looks beautiful, and patients love it, and they come back all the time for it. And like, that's the one thing that the patients love. And but it's only a traumatic nail. It's not like I don't do it on like fungal nails that much. And you have to have something to attach to.
Yeah. Yeah.
So that's that one. Yeah. What else? What other questions?
You're always trying, not you, I mean, one is always, as far as the per visit value, I hear these numbers sometimes from when you go to practice management seminars and other doctors, and they have this, very high per visit values that they have. And, sometimes you wonder what is it different that they do that, that brings it up so much? Like, you know what I mean?
Yeah.
So I know some of these services contribute, but just wanted to pick your brain.
These don't. Yeah. those don't contribute big to it.
They don't, right? Yeah.
No, they're not those ones.
What would you recommend? Like, how would you go about evaluating and reassessing, protocols or?
Yeah. Do you know your per visit value? Is it like 90 or 70? Or you don't, your medical record doesn't tell you?
125.
125. Okay. That's decent. Some guys get up to like 150 or 160. That's about where we're at.
Yeah.
140. You're not much below 140, 160, depends on the month. I don't know if anyone's doing like a whole bunch more, but that's about, and that's all of them, even like the follow-ups and the things like that are low level.
Yeah.
The only guy that I interviewed that does it a lot would be Jonathan Moore, because every patient is getting a bilateral AFOs for his balance braces. And I don't do many balance braces. I can do them, but he has a better system than I do. I personally, so what's working for me now, I can tell you, is shockwave. So we have focused and radial shockwave. And for me, that's really, really increasing the per visit value for my patients. But it's taking a space of a patient that wouldn't be, you know what I'm saying? So it's taking a space from a potential new or follow-up patient, but we have so much space in our office with the other providers that we can do that. So shockwave is working really, really well for me. I recently heard, and I did a couple of podcasts, I'm going to do a podcast on it about follow-up visits. I learned this from Cindy Pezza. Like pretty much all of my new patients get follow-up visits. And this is something I never used to do. And so, for example, I take a nail sample and I'm going to follow up with them because they're a new patient doing a nail sample. I always do a nail sample before I do treatment. I'm going to review those instead of I used to just call them over the phone. So at least gets one extra visit. So I don't have very many PRN visits anymore. I don't just say come back as needed. For the most part, I'm able to build enough value so they'll come back. I do a yearly diabetic foot exam on all my diabetics. I block time all my routines. I only do routine 1 day a week. That's when I do all my routines instead of dispersing them out. Just works better for me. Knowing what levels to bill of visits. But the workhorse for us right now is the shockwave. I do a lot of velocity braces. I do a lot.
What's the velocity brace?
It's like the Donjoy. It's like an AFO, a non-custom AFO. So it's a velocity brace. Any tendinitis, Achilles tendinitis, plantar fasciitis, posterior tibial tendinitis, peroneal tendinitis. It's like an orthotic with an AFO built, and it works really well if you wanted to try it. So when someone comes in with, for example, really bad Achilles, what it does is it reduces the stress going through all those tendons and puts it in the lower leg, just like any other AFO. So it takes, let's say, a portion and puts it in the lower leg. That's how the velocity works.
So you use it like on acute tendinitis?
Yeah, they come right in. So acute tendinitis is, so what are the options with acute, right? You can put them in a cam boot. You can do like a Una boot.
Yeah.
If it's really bad, you do that. But if it's not really bad, then I'll put them in like a velocity, or I'll transition from a cam boot down to a velocity. And then from there, trauma them down into like a stable shoe or an orthotic or over-the-counter insert or something like that. And a lot of those tendinitises now are doing shockwave, just so you know, in my practice, if they're more acute.
Yeah.
Or if they're more chronic. I'm sorry, if they're more chronic.
Brace?
Yeah. And so it's part of my quote unquote protocol, right? So if you've downloaded my under the practice mastery, there's the presentation. So if you look at my presentations within the checklist that I have, and you want to talk about protocols, those are my checklists. That's what I go through, and I show that checklist. So the real, like, if you want to take one takeaway, is just, you don't have to steal my presentations. You can use the presentations, but if you just use the checklist. So a patient comes in, that gives you all the options of that you can do, and you just check them off as you do them. If they're not getting better, you go to the next thing, and it reminds you, it jogs your memory of things that you can do. So peroneal tendinitis, you'll see the velocity, posterior tibial velocity, Achilles, the velocity. It's in there, and just by showing it to the patients, many times, if I'm seeing them 2 or 3 times and they're not better, they'll ask, hey, what's that cam boot, or what's that velocity brace? And I'm like, oh yeah, we haven't tried that yet. Let's try it. So they'll actually ask me because I pull up that slide in my treatment room.
That is pretty cool.
Yeah, the biggest transformation in my practice has been using those checklists and the presentations. And
Is that the
they're all
sheet,
right there.
like you have a sheet like the diagnostics and the diagnosis
Yeah.
and the treatments? Is that what you're referring to?
Yeah, that's it. That's the checklist. Yep. So basically it has the diagnostic images, which are x-rays, ultrasounds, MRIs, and then it has the checklist, the regenerative stuff. And it's basically what happens is we get, like you've heard of this, we get stuck in the nail groove. So I see them like 10 times, they're not getting better. And I don't know what to do. And it makes it objective, not subjective. So I said, okay, Mrs. Jones, let's look here. Have you done physical therapy? Oh, no, I didn't. Oh, well, let's do physical therapy. Have you done a cam boot? No, I haven't. Well, let's do a cam boot. Have you done it just jogs my memory, because sometimes I get like frustrated because they're not getting better and I don't have a lot of time, and
Yeah.
So I would do, if you have, all you need is a Google Chrome, and you just save those presentations, and I'm still perfecting it. I always try, I do it every single day on my patients, and it gets better and better. So then I tweak it, and you guys have access to all those.
That's on the website, Don?
Yeah, that's on in the membership site there under patient presentations, and it explains my whole philosophy behind it.
I'm gonna look it up. I don't think I looked it up. And can you tell me what code you use for the velocity brace?
I'm bad at codes. It's I don't know. I'll find it and let you know. It's this. I think it's the same thing as an ankle brace code. I think it's the same code as an ankle brace.
And you use it for 2 weeks, 4 weeks?
I transition them down. I do it from 2 to 4 weeks, and usually I'm doing it as they're doing physical therapy or as they're doing shockwave, and then they're going to transition out of it. So it's not, I always tell them this is not long-term. What this does, the way I kind of explain it is I push on the lower leg and I say, what this does is going to take pressure off your foot and put it into your lower leg. Kind of like a crow boot, how it takes pressure off the foot and it puts it somewhere else. I say that's how it works. And so it works really, really well with tendinitises. Not so much with plantar fasciitis, but it works more, in my opinion, works more with like Achilles tendinitis if they're really limping around. And it helps. And so the way, and I learned this from Tom Hector. If you haven't listened to my interview with Hector, Tom Hector, he has this offloading brace that he uses, a Podorthus makes for him, but he started out with the velocity before he was doing these offloading braces. And so what he does is he does this regenerative stuff. But if you have loading, if people are loading right through the area that you're treating with amnio and all this regenerative stuff, it's not going to have the best outcome. So he uses these offloading braces to do that, and you can still be active in them. That's the nice thing. It's not like a cam boot where you're totally immobilizing them. So that's why they like them as an option. If you offer anyone, hey, do you want a cam boot or a brace? 100%, they're going to take a brace.
Yeah, that's what's appealing to me about it as you're talking about it, is that patients would probably love it more than the walking boot, just because they get to put their shoes on.
Yeah. Yep. So what I would do if I were you, I would go to my my presentations, and you can look at them, and you have to request it on Google. It'll say, send me a link, and I'll send you authorization, and just pull them up like warts, neuromas, and just kind of look at my checklist. And those are the things that I offer to my patients. It's not a secret. I just do them in different orders. And the key is really to have confidence in what you're doing. Like, and that means usually learning stuff like the Keryfex, the Onyfix, the shockwave. Ultrasound. I did ultrasounds for free for a long time till I got confident. So do them for free. Who cares? That's how you learn, and you build your confidence, and then you can charge.
Yeah. Which ultrasound do you use, Don? Doesn't matter.
I think that 2021 or whatever, it's a real expensive one. I don't know, it's like real expensive, but we have two of them. We have one in each office. I use the ultrasound every single day. So another thing you asked about, increasing per visit value. So every patient gets an x-ray the first visit, and I say, Mrs. Jones, on the next visit when you come back in, depending on your doing, we're going to do an ultrasound to evaluate the thickness, and I compare right side to left side. That's the key. And then also pre-shockwave and post-shockwave, I do ultrasounds, and they love it. And then they take their camera out, they take a little picture, just the same way they like to take a picture of their x-rays with their phone, and they should tell their friends. Like, I ask everyone to take a picture of their own x-rays and their ultrasounds. They love it. Then they post it on social media, and I ask them, hey, I just thought about that now. Hey, could you post this on social media and say you saw Dr. Pelto?
Oh, wow.
So
That's
what
brilliant.
I feel like I need to improve on, and just being frank, is I have a buddy here. He does tons more orthotics than I do. I do 5, 10 pairs a month. I don't do 15, but there are some guys that do 30 and 40, and I haven't figured out, like in Massachusetts, the insurance doesn't cover them. So I don't know if you have anything you could teach me about orthotics. I'd love to hear. You have any good tips about orthotics?
Yeah, I do a lot of orthotics. I watch them walk. I do gait analysis on every new patient.
Mm-hmm.
And even if they come for an ingrown nail, I would watch them walk. And if I see severe pronation, I would ask, do you get any ankle pain? Do your feet ache you? Do you get any knee pain? And more often they're not, they'll say yes. I'll say, that's because you have flat feet. Would you like to talk about it a little more? And we go from there.
So keep going. Okay, I've gotten there, and then, like, why not just over the counter? Why not just good shoes? Like, how do you explain it?
Well, a big part, a lot of insurances here in New Jersey cover orthotics. So I tell them, the best one is to get is custom orthotics. So
Okay,
I'm going to check.
yeah, I agree. I agree. If it was covered, everyone would have orthotics.
Yeah, that makes it a lot
You're
easier.
not really. It's easy to sell what's free.
Exactly. So I say, let me check your benefits, and very often it's covered either partially or fully, and so that's how it goes.
Okay, that makes sense.
It would be a much upper hill if it was like out of pocket for sure.
Yeah, all of ours in Massachusetts are out of pocket, so
Really,
no insurance is covered.
yeah.
Okay, I should move to New Jersey. No, it's good to know though. I like that. I don't watch. It's a good thing to take away. I don't watch my ingrown toenails walk. Right, that's a good thing. I should start doing that. I do for my Achilles, plantar fascia, any other things. I watch them walk, but I'll start doing that. And I think it's having the conversation, right?
Yes,
About it.
and
That's good.
also kids. I have some pediatricians that I've built relationships with over the years, and kids, they get those. They have a lot of flat feet, and they play sports. Now, out of COVID, most of them were sitting home gaining weight, and now they're back in gym, and a lot of them are getting pains in their feet, getting tired, so we see a lot of those too. Pediatric.
Yeah, those are, or like Severs or things like, yeah, we see the same thing.
Mm-hmm.
Good. Orthotics, good. What other things do you think you're doing really well that you could help people that are listening? What do you think's working well for you in your practice?
We do laser therapy. I don't have the shockwave, but I have laser, class 4 laser. So I use it for tendonitis. I use it for heel pain, toenail fungus. Those are the 3 main things we use it for.
So tell me your protocols, and I don't know if you remember which one it is. You probably have a better memory than I do.
If they come in with tendonitis, I'll tell them, I'll immobilize them in a walker, or now I'm going to look into the velocity brace, obviously. But then I'll say we need to address the inflammation, and the easiest and least invasive way is to do laser therapy.
Okay.
And when they agree to it, I say it's not covered by insurance, and this is what we charge. And I would say it's maybe 50-50, 60-40.
Is it like 100 a treatment for like 6 treatments, or 50 a treatment? How do you charge?
I charge. I do 10 treatments, and I charge 700.
700?
Yeah.
Okay.
So 70 per treatment.
Yeah. So, and it doesn't take your time. That's the thing. My shockwave takes my time, and it probably gets the same results. That's what I love about that.
Yes, I have the robotic machine, so I'm not in the room doing it for the patient.
You're better than me in that, because the shockwave, it takes time,
But I hear it works really well, shockwave. I'm very intrigued by it.
I trust the science behind it.
Yeah.
right? So basically everyone that's getting your laser, and I've talked to another guy, I did an interview with Dr. Bromley, and he said the same thing. He said, Don, I would do shockwave. I just don't have time in my schedule. Because like I see these people 3 to 6 visits every week,
That is a lot.
once a week for 3 to 6 weeks. And you do too. You do it for 7 weeks, for example, or 10 weeks. But like you don't have to see them. I have to see them. But I like the science behind it. And we charge like you do 70, we charge 150 for the radial and 200 for the combo, for the focused and radial. So, you know, if yours is working, keep doing it. So that's good. Now let's talk about laser fungus or nail fungus, because you know, just between you, me, and the other 20 people that are listening, I don't have good results. It works for mild to moderate sometimes, but I'm still doing a lot more Lamisil. I wish I had the magic laser, but I don't own it.
I don't think there is. I
Okay.
think it's a combination. You know, I do a little bit of a cocktail. I do like 3 laser treatments and 3 weeks of Lamisil, and I found that we get better results that way.
Good.
Patients still prefer the 3 weeks to the 3 months of Lamisil.
That's what I was going to say. I like that because you're giving them a happy medium with that.
Yeah.
Yeah, because everyone's scared of it. I've never had a problem. Have you ever had a problem with Lamisil?
Some patients, when you tell them I need to do a blood test, they're like, oh, you know, but
a real allergic reaction or liver problem.
No.
I've never had anything. Yeah.
I've had some patients who've had their enzymes go up. Very few, but I have over the years. I had one patient who lost taste. One patient in my once. And I get a lot of them who complain about headaches.
Okay. Yeah, I've had one that had a rash. And but other than that, I haven't had anything. Well, good. Well, anything else? I think we covered a few things. So the velocity you're going to try. Look at the presentations. I think you're going to like them.
I will.
And then if you have any other questions, you have my email. I'll shoot me an email. Okay.
Thanks so much for your time. Appreciate it.
Okay. Well, it's nice to have this community because we're so lonely, all practicing alone. So it's not. That's why I kind of like doing this. I get to meet people. So if I have something else going on, I'm thinking about starting a mastermind in the future. I'll let you know. Okay.
Please do. Thanks so much.
Okay. Have a good one. Thanks for your time.
You got it.